week, we're doing urodynamics, the second half. If you haven't watched the first half, be sure to check out the first one. But I'm going to be talking about interpreting urodynamics. We're going to go over a lot of different scenarios and look at different printouts. I'm going to try to make it interactive, so it's going to be best to watch it live for that reason. Second reason is SUNA is also offering a urodynamics course that's taught by Dr. Michael Gray. If you've never heard Dr. Gray speak before, he is a great speaker. I've heard him several times. Very knowledgeable in urodynamics. Far exceeding what I find in Illinois. They've offered UroNurse one free admission, which is a $250 value. And we're going to be able to raffle that off next week. So you have to be live if you're watching, no matter how you watch it, through the comment box. I'm going to give you a secret word to put in. And StreamYard is able to actually do a raffle draw. So it's completely random. The system does it all for me. But we're going to do that to go ahead and raffle that off. So be live. Good reason to be live next week. Because of the internet issues that we're having, I'm going to bring Dr. Guralnick on right away here. Well, I know I've got good internet working. Bring your presentation up here.
All right.
There we go. All right. Take it away.
All right. Thank you, Vic. And glad to see where the internet's up and running for the time being. Hopefully it stays that way. I want to thank Andrea for inviting me to participate. I didn't know this entity exists, and I think it's a fantastic way for people to communicate and learn. I think this is fantastic. Congratulations on that. So I'm going to start talking about overactive bladder, and we've actually divided this into 3 modules. And this is the first module, basically defining what it is and how we go about evaluating it. I believe Andrea is going to talk about at a later date first line and second line therapies to treat it. And then my colleague Corey O'Connor is going to talk about the more advanced treatments. So I figure we better start off just with basic bladder function. Our bladders are relatively simple organs as far as what they do, but they have a complex regulatory process. They only serve 2 functions. They store urine and they empty urine. But those functions require a complex interplay between the bladder itself, which comprises the detrusor muscle and the urothelium, the lining of the bladder, the urinary sphincters and pelvic floor muscles, and then probably most importantly is the nervous system. And it's all components of the nervous system, the peripheral, the autonomic, and the central. And one crucial aspect of it all is the central nervous system's control over things. And basically, the central nervous system generally functions to keep things quiet. There's this what we call descending inhibition. I don't want to scare people with this slide, but this is what I show medical students and residents just to show the complex interaction. The nervous system has a central component, which is the brain and the spinal cord. Then you have the autonomic nervous system, which comprises the sympathetic and the parasympathetic. And the sympathetic nervous system is our fight or flight system. It's when you get excited, that's your sympathetic system getting activated. And the prime function of the sympathetic nervous system, as far as the bladder goes, is to promote urine storage, which, makes perfect sense. If you're running away from someone who's got a gun, the last thing you want to have to do is stop and take a leak. And so the sympathetic system keeps the urine held in the bladder via what are called beta receptors that promote relaxation of the bladder muscle, and then alpha receptors that actually help to tighten up some of the sphincter mechanism. Whereas the parasympathetic system, which is our housekeeping nervous system, that promotes urine emptying and does so through cholinergic, or acetylcholine being the nerve transmitter, to stimulate the detrusor muscle. And then our somatic nervous system, which is what we have voluntary control over, is what controls our external sphincter muscle. And then the brain, the CNS, controls everything and pretty much is constantly sending inhibitory signals to keep that bladder quiet. This is, again, just showing you the receptors. And the only reason I put this on is because the standard medical treatment for an overactive bladder, which I think most of you are familiar with, are bladder medicines like oxybutynin and tolterodine and sulfenacin, and the newer ones, mirabegron and vibegron. This is how they work. So you have the cholinergic receptors, the acetylcholine being the nerve transmitter that stimulates the bladder muscle to contract. Its receptors in the bladder muscle are called muscarinic receptors, and the medicines that we use to calm down the bladder block those receptors. They're called antimuscarinic. That's the oxybutynin, tolterodine, sulfenacin. So they prevent the bladder muscle, or they try to prevent the bladder muscle from contracting. Whereas the other class of drugs, which are our beta agonists, they activate basically the same way that the sympathetic nervous system activates a receptor, and that's to promote relaxation of the bladder muscle. So our medicines like mirabegron and the newest one, vibegron, they bind to that beta receptor to activate it, and in so doing, promote bladder relaxation. So our storage and emptying function of the bladder is basically like a cycle. And if we start at the urine storage phase, let's say the bladder had just emptied. So as the bladder is filling up with urine, it's sending signals up to the brain saying, hey, I'm starting to get full. But the brain is constantly sending inhibitory signals to keep that bladder quiet. And that's why we don't sit and wet ourselves all the time. Well, at least most of us don't. Unfortunately, some of us do. But those inhibitory signals keep the bladder muscle at rest to let the bladder expand. And then simultaneous with that, our sphincter muscles are contracted to keep the outlet tight. At some point, the brain decides, hey, I've had enough of this input from the bladder. It wants to go. We're going to let it urinate. The brain decides it's time to pee, so it releases that inhibition of the bladder, and now the bladder is ready to contract. Immediately before that happens, we voluntarily relax our external sphincter, then the bladder contracts, and then the internal sphincter, or what we sometimes refer to as the bladder neck, also relaxes, and now urine flows out until the bladder is empty, and then the process starts over again. Now, overactive bladder is a dysregulation of all of that. And its definition, at least according to the International Continence Society, is a syndrome characterized by the symptom complex of urinary urgency. You got to get to the bathroom in a hurry, with or without urge incontinence, so you can be dry or wet, usually associated with urinary frequency, you have to go often, and nocturia, you have to go several times at night. And the technical definition of an overactive bladder implies that you can't find any obvious cause for this, meaning you've basically ruled out other pathology. And so that's the true definition of an overactive bladder. Having said that, we'll often refer to patients who have prostate issues or even UTI issues who have perhaps the same symptoms and say they're having overactive bladder symptoms, but because there's a defined cause for it, technically you don't label them as overactive bladder. And again, overactive bladder is basically a spectrum where you have both, you have some patients who just have the frequency, urgency, and nocturia. Other patients will actually wet themselves with that urgency and have urge incontinence. So we define the patients who leak as having wet OAB versus those who don't wet themselves as having dry OAB. So differentiate the urination process between normal and overactive bladder. We see on the x-axis, you have the time, and then the y-axis, the vertical axis, is the bladder volume increasing. So as that bladder volume starts to increase, we start to get the sensation. Again, our brain is inhibiting it, so the volume is allowed to continue to increase. That urge gets even more. And then finally, you reach the point where the bladder says, enough, let's go. Then you urinate, and then the volume, then you see the arrow on the far right. That's our voided volume, is all the urine that was in the bladder. And then the process would start over, and the time between the moment the bladder is empty till the next moment that urination occurs is what you call the intervoid interval. Well, with an overactive bladder, the bladder decides it wants to go before it's technically really full. And so you get that sudden urge episode and potentially have to urinate immediately, which occurs much sooner and at a much smaller volume than what would be considered normal. So these people go often because the intervoid interval is reduced because of that sudden urgency episode at a lower volume, and then the amount that they actually urinate is smaller than what would be normal because their bladder was never really getting as full as it could. And that's what an overactive bladder is. The bladder lies to the patient, telling them that it wants to go, that it's full, even though it's really not. What causes it? Well, in truth, we don't know the true specifics. There's a lot of theories. And in some cases, it's thought that the bladder muscle itself is dysfunctional. So that's considered the myogenic or muscle hypothesis. There's some thought that the urothelium, the bladder lining itself, plays a role in perhaps being more permeable to irritants and things. Plus, it actually sends chemicals that talk to the detrusor muscle as well as the nerves. There's even thought that the space between the bladder lining and the muscle, called the suburothelium, has chemicals and communicators that stimulate nerves as well as the detrusor. Then, of course, there's the nervous system itself. Now, they only had the central and autonomic listed, but you could even argue the peripheral nerves, just basic nerves that form sensation and motor beyond the spinal cord. If they're dysfunctional, can potentially affect the bladder. And lastly is the urethra itself. That's actually the hottest new topic when it comes to bladder dysfunction, is the role that the urethra plays. There's some thought that if urine just happens to leak a little bit into the urethra, that can trigger an overactive bladder via a reflex that occurs between the urethra and the bladder. Then you have these aggravating issues, which are predominantly patient factors that basically pour gasoline already on a fire. Not uncommonly, people who have the so-called metabolic syndrome, where they've got central obesity, often with impaired glucose control, such as diabetes, hyperlipidemia, cardiovascular disease, hypertension. These patients are much more prone to having overactive bladder issues. Women who are in a hypoestrogenic state, such as they've gone through menopause, or perhaps they're taking hormone blockers to treat breast cancer, can lead to tissue changes in the genitourinary tract that makes the bladder more sensitive. Any inflammatory process can obviously irritate matters. Most commonly would be urinary tract infection, but prior radiation treatments and even certain dietary irritants can play a role. And lastly, something that for whatever reason goes often unrecognized, even though it's obvious, is polyuria, people making too much urine. And probably most commonly caused by polydipsia. They drink too much because, you have that old adage that you got to drink your 8-ounce cups of water a day in order to be healthy, which is great. That's 64 ounces. Provided you're not also drinking your 3 cups of coffee, 4 cups of juice, soda, etc. There's also edematous conditions, people who have swelling in their extremities from venous insufficiency or CHF. All of that swelling is water that's being excluded from the cardiovascular system at that moment. But of course, when they lie down at night, all that water comes back in their system. And now they've got all this excess water that they got to get rid of, which they do via urine production overnight. Another major one is sugar in the urine, glycosuria, which obviously is what diabetes causes, but certain diabetes medications also cause it. In fact, that's how a medicine like Jardiance works. It works by preventing the kidney from reabsorbing or encouraging the kidney to excrete glucose. So that's how it keeps the blood sugars low, because it's all getting excreted in the urine. The problem is when sugar gets excreted in the urine, it brings lots of water with it. So people end up making much more urine than they otherwise would. And then, of course, the last one, which is, again, obvious, but it's amazing how many primary doctors never warn their patients and how many patients don't put 2 and 2 together. If you're taking a diuretic, you're going to make lots of urine. That's what diuretics do. In fact, you make lots of urine at a much more rapid pace than you otherwise would. And of course, if you're making lots of urine and you've already got some underlying bladder dysfunction that's causing an overactive bladder, well, that's like pouring gasoline on a fire. Overactive bladder is relatively common. In fact, this study, which is already now more than 10 years old, which was a survey where they questioned people, otherwise thought to be healthy people who about certain overactive bladder symptoms. As you can see, from middle age going up, it's common. Now, early on, it's more common in women, but once you get into the 70s and 80s, it's roughly equal, partly thought to be related to the prostate rearing its ugly head in older age. But we've now come to realize the prostate isn't always the cause of the problem in men. In fact, in many cases, it's not, even though it's assumed to be. And even though we hate to say that overactive bladder is not a normal part of aging, when you're getting close to 50%, if not more, of a population to experience these things, then you have to wonder, maybe it is part of the aging process. It obviously impacts patients and can have a severe impact on their quality of life, particularly patients who wet themselves. But even those who know that they're going to have to urinate, every hour or so, they don't want to go to events that are going to have them be away from or not near a bathroom for easy access. And that can, lead to psychosocial problems, work-related problems, even physical problems because they reduce their activities. And then, of course, they might even have personal and sexual issues because, again, the fear of embarrassment related to the problem. There's more to it. It can even contribute to physical morbidity, especially orthopedic. This study, again, which is already now 23 years old, but showed that in patients who had weekly urge incontinent episodes, there was a 26% increase in falls and a 34% increase in fractures. If they had daily episodes, those numbers got even worse. And they calculated that about almost a quarter of the cost of complications associated with urinary incontinence were related to the treatment of falls. So this is a real issue that we're now seeing more and more as the population ages. So again, you don't have to know all of this. This was just to show you that there is a evaluation and treatment pathway that's been created by the American Urologic Association, AUA, and SUFU, the Society of Urodynamics and Female Pelvic Medicine and Urogenital Reconstruction, on walking through a patient with an with urinary symptoms. So starting with the history and physical, what are the kinds of questions we want to know? Well, first, you want to know how frequently do they go? So how often do you go? Every hour, every 2 hours, every 3 hours? Now, patients have a tendency to exaggerate, but I find one, useful question is, can you sit through a 2-hour movie without going to the bathroom in the middle of it? That gives you an idea, because if they're urinating more frequent than every 2 hours, that's pretty frequent. How many times do you have to get up at night to go? That one's not so difficult to answer. Do you have to urinate urgently, and does it hit you all of a sudden and sometimes make you leak? Another way to phrase that question is, if you feel the need to urinate and there's somebody in the bathroom, can you wait for them, or do you have to hunt down another bathroom in a panic? And then lastly, do you wet yourself, and do you have to wear pads, or do you have to change your clothes? How often? How many pads a day? What kinds of pads gives you an idea of the severity? How wet are they? You also want to know about other symptoms. Stress incontinence. Are they leaking urine with coughing and sneezing? Do they have any difficulties urinating or avoiding symptoms? Do they wait a long time for the flow to start? Is the flow real weak? Do they have to push? Do they have intermittency where the flow stops and starts? Probably the most important question of all, do they have blood in the urine? Hematuria. Do they have pain when they urinate, or do they have a history of urinary infections? We also want to know about a neurologic history, because, as I said, the nervous system plays such an important role that any dysfunction of the nervous system can affect the bladder. So is there any history of stroke or Parkinson's or MS, a history of spine injury? Do they have neurologic symptoms, numbness, tingling, weakness, blurred vision, which is often an early symptom of MS? In fact, about 10% of MS patients, the symptoms start with an overactive bladder issue, and about probably more than 70% of MS patients will complain of overactive bladder issues. Have they had prior surgery? Probably most important. Any previous urologic surgery, especially incontinence surgery, because one of the complications of incontinence surgery is that the bladder can potentially become overactive. Any history of back surgery or brain surgery, again, suggesting a possible neurogenic component. And what about smoking? Because smoking causes bladder cancer. So if you have a patient who's got a 50-year history of smoking and now they're developing a relatively recent onset of these overactive bladder symptoms, you definitely have to be thinking about possible bladder cancer in the back of your mind. I find that a great way to get patients to give you what kinds of symptoms they're experiencing are using symptom questionnaires. So we routinely use the AUA symptom index. Ideally, I'd also use that OAB symptom score, which is more focused for overactive bladder. But I find it's tough to get patients to fill out multiple questionnaires. So at least with the AUA symptom index, you actually get questions both on the storage of urine, there's frequency, urgency, nocturia questions, as well as questions about any difficulties urinating, intermittency, weak stream, the need to strain. And then there's the quality of life, which almost gives you an idea of the degree of bother. And that's the question, if things were to stay they were today for the rest of your life, how would you feel about them? This gives you an almost a more objective way to assess their symptoms. And it also allows you to grade the severity, and then you can use these questionnaires to track their progress as far as treatment and stuff goes. So I find these questionnaires to be tremendously helpful. And the bottom line is when we're evaluating these patients, we're trying to rule out pathology that potentially can be the cause. Because as I said, the technical definition of an overactive bladder is when you've ruled out what might be causing it and you can't find any other obvious cause. So we're going to label this as overactive bladder. So first and foremost, we want to rule out infection, UTI. That's going to be hands down the most common cause of these symptoms. But there's the potential for bladder stones. Granted, those are pretty rare. But as we talked about, bladder tumors, so-called interstitial cystitis, I don't really want to get into. But the main feature of that is a pain component to urine holding. Any potential obstruction of the urethra, such as BPH in a male patient, or urethral stricture, or previous surgery in a female. Again, you definitely want to know about their medications, because if they're on diuretics, to some degree, they're going to have to put up with some of their overactive bladder symptoms, because that's a side effect of the diuretic. Certain medications, if antihypertensives, have diuretic components. Obviously, estrogen deficiency and any neurologic issues, and then metabolic factors such as diabetes. And then again, that issue about fluid consumption, as well as any peripheral edema. When we, the formatting totally changed on this. When we examine patients, there's not a lot to find on examination. Your abdominal exam, we just are looking for, do they have any evidence of a distended bladder to suggest that maybe their real problem is urinary retention and they're kind of just overflow. Neurologically, we want to make sure their sensation is normal, and that the reflexes are normal. And from a genital urinary exam in women, we want to see the degree of vaginal atrophy. Do they have any prolapse? Can we actually make them leak with coughing to show us that there is, in fact, any stress incontinence? And then, very importantly, what's their ability to control their pelvic floor muscles? And I do that with a digital finger exam of the vagina and have them try and show me a Kegel contraction. And then I actually teach them how to do it, because that's going to be the first line of therapy. In the male patient, we do rectal exams to get a feel for how large the prostate is, although that's not necessarily all that reliable. More so, it's also to look for nodules in the prostate. And then you can assess whether the male patient can do a Kegel through a rectal exam by having them squeeze, because men should do Kegels too when it comes to these symptoms. As far as the most important test that we do, hands down, it's a urinalysis. If you're only going to do one test on a patient besides, let's say, a physical exam, then that test should be a urinalysis. And you're looking for, is there any microscopic blood in the urine? If you see more than 0 to 2 red blood cells, in the urine, which by definition is microscopic hematuria, but if that's associated with any type of urinary symptom affecting the bladder, frequency, urgency, even voiding difficulties, that's bladder cancer until proven otherwise. That patient automatically has to get scoped, and you have to prove it's not bladder cancer unless you have another reason for microscopic hematuria. Let's say they actually have a UTI at that time. So you're also looking for white cells in the urine, pyuria, that leukocyte esterase. But if you have no suggestion of infection and they've got microscopic blood in the urine and they're having overactive bladder symptoms, it doesn't matter what age they are, they've got to get scoped to make sure they don't have a tumor in their bladder. And then on the urine test, you also look for sugar in the urine, glycosuria. As I said, diabetes, that's one of the main symptoms of diabetes in poorly controlled diabetes. But then, of course, it's also the mechanism for diabetes medications. And for whatever reason, patients aren't told this or they ignore it. But if you're going to spill sugar in the urine as part of the treatment of your diabetes, you're going to urinate more frequently. Urine culture is indicated if the urinalysis is suspicious for infection. Urine cytology is not part of the routine urine testing for overactive bladder symptoms unless the patient's already got a history of bladder cancer and now they're having these symptoms. Or you could even consider it in someone who's got a real strong smoking history, and let's say they have a relatively recent onset of these types of symptoms. Nobody would fault you for being suspicious for possible cancer in that type of patient and checking a urine cytology. Other issues we already talked about urine culture. What about a post-void residual? Well, I mean, we check it because we're urologists. We have bladder scanners. It's easy. The question is it really necessary? I mean, ideally, the patient's going to have a PVR less than 100. But to some degree, it depends on what they started with when you ask them to urinate. If they didn't have, all that much in the bladder and they didn't really have to pee, and then you have them pee for you, they might end up retaining a little bit, whereas normally they wouldn't. Or just the on-demand requirement. Some patients are anxious. They can't urinate well on demand, and they may end up retaining. So bottom line is a single PVR measurement really doesn't rule in or rule out avoiding dysfunction, but what it might do is at least prompt you to maybe recheck it at a later date. But the bottom line is the average healthy person, middle-aged, who doesn't have any major medical issues, really doesn't need their PVR checked as far as the initial workup for an overactive bladder. The ones who are at risk are going to be patients with neurologic conditions, diabetics, patients who are already complaining of difficulties urinating. Well, then you want to make sure that they are emptying, perhaps the frail elderly, and women with real, significant vaginal prolapse where it's already protruding, to the introitus or beyond. They're going to be at increased risk for emptying troubles. I said urine testing is the most important test. I would argue the second most important test is a bladder diary. And, I have access to the fanciest urodynamics and the best urodynamics nurses who do them. And I hate to say it, if I had to choose one over the other, give me a bladder diary over video urodynamics when it comes to the average patient who's got overactive bladder symptoms. A bladder diary is literally what it sounds like. We get the patients for over a 48 to 72 hour period. They literally will measure and record each time they urinate what the volume is. We give them either a urinal or a hat to put on the toilet, and then we bring them back at a later date to review the diary. And the goal of the diary is to show us their typical bathroom habits. We don't want them, and I tell them, I don't want you changing when you decide to use the toilet just because you're doing the diary. But the diary provides a tremendous amount of information. You can determine what their urine output is over a 24-hour period. You can even break it down to what it's like during the day versus night. You can figure out what's their functional bladder capacity. The largest voided volume tells you what's the most they want to store in their urine. You figure out what their average void, their average urinary frequency. You can even have them log each time they wet themselves and what they were doing, because that can help differentiate urge from stress incontinence. This is an important underused tool. As far as normal bladder behavior, in order to figure out whether a diary is going to be useful for you, you first have to know, what's considered normal. Most patients will urinate roughly 8 to 10 ounces, between 250 to 300 milliliters of urine at a time. Most patients or most people's bladders can store 300 to 500 milliliters routinely, so about 10 to 16 ounces. Lots of people can go more. Most people will produce 1,500 to 2,200 milliliters, 50 to 70 ounces in a 24-hour period. And most people wake up at most once at night to urinate. Once you get into the older age, 70s, waking up twice is probably normal. This slide shows you how a diary really is important. Here you have two patients, both complaining of frequency and urgency, and they both urinate 15 times in 24 hours. So this is why having the patients measure their voided volume is important, because if you just had them do a diary where they just log the time and how often they go, but not the actual volume, you have the same issue with these two patients. But when you have them measure their volumes, you can clearly see a difference. One patient's producing 5 liters in 24 hours. The other one's 2 liters. One patient's maximum void is 700 milliliters, a good-sized bladder. The other one is only 225 milliliters. One patient's on average urinating 400 milliliters at a time. The other one's only 150. That first patient is just making too much urine, probably because they drink too much. The second patient has an overactive bladder, but they both complained of the same problem. Unless you did that diary, you wouldn't know the difference. And if you treated them both the same and you put them both on overactive bladder medicine, it's only going to help one of them. So again, I can't stress enough the importance of a bladder diary. Here's another issue where the diary really comes in handy. Most patients are bothered, probably mostly, by having to wake up at night to urinate. Nocturia is an incredible nuisance, and it affects your quality of life because it interrupts your sleep. Well, the bladder's not the only cause, and neither is the prostate for nocturia. In many cases, the problem is the patient's making too much urine, and we call that nocturnal polyuria. And it's defined as nocturnal output that's more than 20% of your total 24-hour output in younger people aged less than 65, and up to about a third of your 24-hour output in older people. And the prevalence of nocturnal polyuria increases in age such that up to 90% of 80-year-olds and older actually experience this. Well, what causes it? Well, a major cause is actually sleep apnea. And so when I hear patients that are complaining of nighttime, especially if they wet themselves at night, and especially I ask the spouse, are they a snorer? We send them for sleep studies, because sleep apnea causes cardiovascular changes that result in excess secretion of atrial natriuretic peptide, which causes your body to excrete salt, and guess what? It takes water with it. In some older people, they don't make as much antidiuretic hormone, which is the hormone that normally gets produced at night to tell your kidneys to not produce so much urine. If you don't make as much of that hormone, you end up producing more urine. We already talked about leg edema, dependent edema, so that's venous insufficiency, heart failure, even autonomic neuropathy can cause that. And then, of course, people who drink too much at night, especially alcohol. But again, unless you get them to measure these things, you're not going to figure it out. Well, what about cystoscopy? I mean, I'm urologists, you guys are urology nurses. This is our bread and butter. Unfortunately, well, maybe fortunately for the patient, cystoscopy is not really needed for the initial evaluation of an overactive bladder, unless any blood in the urine, that's automatic. History of bladder cancer, that's automatic. You could argue a significant smoking history, which we know causes bladder cancer, especially if it's a relatively recent onset of overactive bladder symptoms. Nobody would fault you for doing the scope. And if you have any concerns about the urethra, let's say they've had previous, instrumentation of their urethra or sexually transmitted diseases, both of which can cause urethral strictures, particularly if they have a poor flow, you might consider a scope in that scenario. I briefly mentioned urodynamic testing. What about that? As I said, I have access to the fanciest urodynamics, and our nurses are superior when it comes to doing urodynamics. But in truth, you don't need urodynamics to diagnose an overactive bladder. In general, urodynamics testing is only needed if the results are going to affect your management. And yeah, it's useful for identifying certain things. So you want to rule out the prostate causing an obstruction, right? Urodynamics can help with that. It can help diagnose stress incontinence, especially if you were unable to diagnose it in the clinic. You can do it during urodynamics. You can also evaluate the storage pressure of the bladder, how, its compliance, how stretchable it is. But that's really only a concern in patients with neurologic conditions where low bladder compliance can actually lead to kidney damage. And then the other issue is urodynamics is notorious for missing bladder hyperactivity, what we call detrusor overactivity. There are some reports where it can miss it up to 50% of the time. So if you have a patient with an overactive bladder who has got the symptoms of an overactive bladder, and you do urodynamics and they don't end up showing you detrusor overactivity, that doesn't mean they don't have an overactive bladder. It just means that the test missed it because urodynamics isn't perfect. So in a patient who has classic overactive bladder symptoms, there's really limited value in doing urodynamics just to see, do they have detrusor overactivity? I'd argue it's a waste of time because it's not going to change your management. You're still going to treat them as an overactive bladder. And studies have actually shown patients who have those symptoms, and one group that has detrusor overactivity versus the other group that doesn't, they both respond well to overactive bladder medications. So that's the end of my talk. This is just part one. As I said, parts 2 and 3 will be on management. But just to summarize, overactive bladder is a common clinical entity that really affects patients' quality of life. It's a diagnosis based on symptoms and the exclusion of other pathology that might be the cause, and your evaluation is basically done to rule out said pathology, most importantly, urinary tract infection, cancer, I'd argue even excess fluid, and basically the two, what I think are the two most important tests, urine testing, urinalysis with or without culture, and a bladder diary are my go-to tests for the evaluation. So once again, I want to thank UroNurse for inviting me. I think this is great, and I look forward to some questions.
Thanks, Dr. Guralnick. That was a great presentation. Are you able to hear me?
Mm-hmm.
Great. So I just had some information I wanted to share with the audience. For those SGLT2 inhibitors, those are the medications to treat diabetes that purposely cause the patient to spill sugar into their urine. Always end in the flozin, F-L-O-Z-I-N. So it's pretty easy to remember. Urine flow, flozin, easy way to see if the patient's on an SGLT2 inhibitor. So Vic is having some internet difficulties, so I'm going to be reading off the questions from our participants today. So we have a comment from Jennifer. Great job, Mike. Thank you.
Hi, Jen.
I'm not seeing any other questions coming through here. Oh, Neil Smith has one question, or comment rather. Great information. Thanks for presenting.
Pleasure.
Another piece of information that I want to share with the audience is the importance of exams on these patients. I would say once a quarter, I'll find a patient who actually has a really high tone pelvic floor. And if I instruct that patient to just do Kegels, I'm not doing the right thing for them. So physical exams are really important for these patients.
Yeah, in fact, I kind of glossed over that as far as the pelvic floor is a huge influence on bladder symptoms. And in fact, I find in many cases the bladder gets blamed. These patients are labeled as having so-called interstitial cystitis, and everybody's blaming the bladder. And then you examine them, and they actually have this high-tone pelvic floor dysfunction. But what's more impressive is that you can sometimes scope these patients, and I can poke my scope into various sites on the bladder, and that doesn't reproduce their pain. But then you press on their pelvic floor muscles, and they jump off the bed saying, yeah, that's my pain. And not only does it cause pain, you can be pressing their pelvic floor muscles away from the bladder, and yet it stimulates the urge to urinate. They say, yeah, I got that painful urge to pee when you push on their levator muscle and you're nowhere near pushing on their bladder. And that just tells you that it's a pelvic floor issue. And of course, the trying to tell them to do Kegels is the exact opposite. They're already too tight. Those are the patients that I don't even waste my time trying to train them to do any exercises. I send them straight to physical therapy. And then the goal of the therapist is to actually get these muscles loosened up and reestablish their full range of motion.
Thank you. We do have one comment here from Charlene Vollmer. Thank you, Andrea, for helping out today. You're welcome. Also, the plug about the urodynamics course is happening in Chicago. I didn't know that. So that's great. I'm just going to quickly check and see if there are any questions coming through on our other platforms, on LinkedIn, on Facebook Live, or on YouTube. Mike, I had a quick question. I believe I've heard you speak in the past about certain bladder irritants that are known to be the worst. Can you share any information about that?
Well, the notorious ones are caffeine, alcohol, spicy type foods, citrus, acidy foods. Some people think soda carbonation. It's interesting. I just looked this up again. It never got officially published, but there was a study done in England about almost 20 years ago now. It was presented at an International Continence Society meeting. And what they did is they took healthy volunteers who turned out to, I believe, be the nursing staff that worked in the clinics. And they had about 20 of them. And they had them do diaries where they also graded their urgency levels, and they had them stick to a predominantly one type of beverage. And one was carbonated water, one was regular Coca-Cola, one was regular Diet Coke, and one was caffeine-free Diet Coke. And what they noticed was that the diaries that were the worst, the ones that seemed to be most impacted with both urgency and the frequency and all that, was the Diet Cokes. And it didn't matter if it was caffeine-free or regular. So that led them to conclude that, the carbonation and even caffeine in the carbonated soda might not actually be, because regular carbonated water and regular Coke, there was no significant difference. But it was the diet soda that was the problem, and they thought that maybe it's the artificial sweeteners that are the real irritants to the bladder. So you now have my permission to drink lots of regular Coke with all its sugar and avoid that Diet Coke.
Yeah, a lot of my diabetes patients will say, "Oh, I switched over to diet soda," and that really affects.
So between that and their Jardians, they're peeing like racehorses.
Yeah. I also think it's important for our audience to remember to ask patients, what are you drinking every day and how much? I can think of a few patients. One guy was just drinking a bottle of wine before dinner, and that explained his nocturia. I do have a lot of older patients who really enjoy a happy hour, which is great.
Too.
And after some discussions with them, sometimes they're agreeable to even moving that drink up a little earlier instead of, having an after dinner drink, moving that up to earlier. That can help with some nocturia as well.
Sure.
So we have a comment here from Vic. Remember to tune in next week live to enter in the giveaway for the Urodynamics course. I didn't see any other questions coming in on our other platforms. Anyone on our live stream who has some questions that they'd like to ask, feel free to put that in the chat box here.
And one other thing is just about bladder diary. So sometimes, especially if we see that there's polyuria, too much urine, you then have them actually keep a log of what they drink so that they can see for themselves. When they drink earlier in the day, guess what? It's all coming out at night. So that you can even have them do that right off the bat. They can do both an intake and an output diary. The onus is all on the patient. And I tell them, look, this is a condition that requires a lot of self-help. We don't have magic that gets rid of it completely. Even our fancy Botox and neuromodulation treatments, in many cases, we're happy if we get a 50% improvement. That's, in fact, often the goal. And so there's still a lot of self-help that's required. And so my attitude is if the patient's not willing to even do the diary to help figure out what's going on, and not only does it help you figure out what's going on, you can actually use the diary in some of the treatments that I'm sure Andrew's going to be talking about, timed urination. Well, how do you decide what time interval unless you already know what they're currently doing? Well, the diary can show you what's their typical time interval for urinating now. And then when you do timed urination, maybe you subtract 15 to 30 minutes off their current interval and have them start at that new time interval. Just doing the diary gets people in tune with what their bladder's actually doing. There's even some therapeutic nature to it that some patients will come in and after they've done their diary, their symptoms don't seem quite as bad. So again, you can have them do intake and output. patients are really ignorant about their bathroom routines and even their fluids. So that diary really comes in handy to show them what's really going on.
Yeah, I agree. I had a colleague came in shared the other day, a patient came in for urinary frequency, but could not communicate how frequently that he was going to the bathroom.
I don't even know when someone says I go so frequently, I don't even know what that means until I see a diary, because you might go frequently, but it might be appropriate. Again, if you're going often and you're going 400 milliliters each time, you got a great bladder. Your bladder's doing great. It's not the problem. Is this comment?
Looks like we have a comment here from Sandy Brunello. I really appreciate all the information you've explained today. As a WOCN and a daughter whose father is having a lot of urologic issues, I'm connecting the dots about what's contributing to a lot of his nocturia. Yeah, good. Vic wants to thank you for a great presentation.
Happy to be here.
I'm just going to quickly check our other platforms to see if there's any other questions. We have a comment here from Elizabeth Hernandez. Thank you for the great information regarding artificial sweeteners. See if there's any other questions. All right, so I'm not seeing any other questions coming through right now. We are not going to have, we normally have an after party every week where we all join for a little more like party and kind of hang out with each other, but we're not going to be able to do that this week because of the internet connection. But everyone stay tuned. We do UroNurse every Saturday morning at 9 a.m. Central Time. It's free to everyone. It's live streamed on Facebook, on YouTube, and on LinkedIn. And we hope to see everyone next week. Thank you.
Thank you.